Good afternoon and welcome to the Tufts Faculty Webinar Series. My name is Dr. Joy Kasparian-Federico, and I'm a proud Jackson 1992 alumna and graduate of Tufts Dental School. I am president of the Tufts University Dental Alumni Association and am a board-certified orthodontist in Medford, Massachusetts, with a practice about 5 minutes from campus. The Tufts University Alumni Association is proud to host this unique series, which provides lifelong learning opportunities for our alumni, parents, and friends around the world. For all our attendees, your audio has been turned off to eliminate any disruption from background noise. If you would like to ask any questions, please do so using the Q&A chat function on the bottom of your screen. I'd like to turn the presentation over to our keynote speaker, Dean Nadeem Karimbux. But before doing so, I would like to tell you a little bit about his very impressive background. Nadeem Karimbux was appointed Dean of Tufts University School of Dental Medicine in July 2019. Prior to becoming Dean, Dr. Karimbux was Associate Dean of Academic Affairs and a professor of periodontology at the dental school. Before joining the Tufts family in 2012, Dr. Karimbux served in numerous positions at Harvard School of Dental Medicine, including Director of Predoctoral Periodontology, Program Director of the Advanced Graduate Education Program in Periodontology, and Assistant Dean for Dental Education. Dr. Karimbux has received numerous honors during his academic career, including the Provost Award for Outstanding Teaching and Service from Tufts, the Presidential Citation from the American Dental Education Association, and Distinguished Faculty Awards from Harvard School of Dental Medicine. He has published more than 100 papers, authored textbooks, and lectured worldwide. Dr. Karimbux received both his DMD and graduate certificate in periodontology from Harvard School of Dental Medicine. Dean Karimbux, take it away.
Greetings, everyone. Pleasure to be here with you today to share a presentation on the links between oral health and systemic health. So the title of my presentation today to you is Oral Systemic Links, Fact or Fiction? What we'll do in about 35 to 40 minutes is talk about our current understanding of inflammation, try to understand why individuals have different inflammatory responses, and I think certainly this is very relevant during the COVID-19 pandemic, where we understand that some individuals are reacting very differently to the virus based on certain vulnerabilities, or certainly due to a cytokine storm that might happen in certain individuals. So I do think that that part of the talk is a little bit relevant to our understanding of COVID-19 and why some individuals might be reacting slightly differently to that viral insult. And then we'll talk about the role of inflammation in periodontitis. And in particular, I'll talk about this inflammatory process that happens in the oral cavity that may be linked to cardiovascular disease. That will be my focus, although we do now have some evidence that this inflammatory response that is happening in the oral cavity is also linked to other systemic diseases such as diabetes and the risk for what we call preterm low birth weight babies. Before I begin, I do have to report that I've worked as an educational consultant for several companies. I've been a medical officer and consultant to one company and a consultant for a company called Interleukin Genetics. None of the materials that I'm presenting you today have any conflicts with this work that I've done for these companies. So certainly a greeting from Boston. I'm in our office today and actually have been here at the dental school ever since the COVID-19 pandemic happened. We've been able to run an emergency service and have resumed our clinical and educational programs, not to full capacity, but have certainly been able to resume our clinical activities. Just a little bit of background about our great school, the Tufts University School of Dental Medicine. It's one of the oldest dental schools in the country. We celebrated our 150th year last year. We're currently the second largest dental school in the country. We have about 1,000 students, supported by a world-renowned faculty, many of them practicing in the Boston area. And we have a wonderful staff that supports our clinical research and educational missions. Here's a picture of our dental school building. We're located on the Boston Health Campus. Our vision is education committed to clinical excellence, and our vision is global leaders in oral health. We like to joke here because if you look at our building, which is represented right in the middle here as the tall building, you can kind of see an old part of the building that is light gray, and then a silver part which represents a vertical expansion that we did to add floors to our building. If you look at that image, it almost looks like there's a toothbrush with bristles projecting out to one side and a handle down the other side of the building. So very appropriate in terms of our dental school. So we recognize, as I mentioned, that there has been a real interest recently in inflammation and the role that inflammation might play in our overall health. I'll read this quote here. Suddenly, inflammation has become one of the hottest areas of medical research. Hardly a week goes by without the publication of yet another study uncovering a new way that chronic inflammation does harm to the body. Instead of different treatments for, say, heart disease, Alzheimer's, and colon cancer, there might be a single inflammation-reducing remedy that would prevent all three. Here is a title cover page from Time magazine. Again, talking about inflammation as the silent killer and linking inflammation to many systemic diseases, which are represented on the right side here. Obviously, the one that is most common to a lot of us is the link between inflammation and heart disease. Another quotation, inflammation is probably the background and driving force behind all major age-related diseases. This is from Claudio Franceschi, Scientific Director of the Italian National Research Center on Aging. So I want to give you a little bit of history about how inflammation certainly started to come to our forefront from a scientific basis. This is a study that was published in 2005 by Dr. Ridker and his group. And the background to this study is that they had about 3,800 patients. These patients were taking what is a cholesterol lowering medication called a statin drug. And all of these patients had had one cardiovascular disease event already. So the outcome that they were looking at was whether these patients would have what is called a recurrent cardiovascular disease event. Now, this is a busy slide, but I'll try to summarize it for you. On the x-axis is the follow-up in years, again, of these patients that were now on a statin drug, and they were trying to see whether they had a follow-up cardiovascular event. Now, they also measured the LDL of these patients. We all know high cholesterol and low cholesterol are measured by our LDL levels. But what they also wanted to do was measure the levels of a protein called C-reactive protein. And so here in the graphic on the side with the red and yellow, you see measurements of patients that had high LDL and high C-reactive protein. And the graph on the top, that line that you follow that goes upward, shows the chances of these patients having that recurrent cardiovascular disease event. In the middle, you had patients that had low LDL and high C-reactive protein, or high LDL and low C-reactive protein. Again, these are those graphics on the right that show this step ladder increase, but it's the two middle lines that you're looking at. And then the patients that had the lowest chance of a recurrent cardiovascular disease event are represented as the patients that had the lowest LDL and low levels of C-reactive protein. The take-home message from this study was that patients with low levels of C-reactive protein have better clinical outcomes than those with high C-reactive protein, regardless of the levels of LDL cholesterol. So again, many of us that are on statins recognize that statins lower what is known as a risk factor for cardiovascular disease, LDL. But here was evidence saying that C-reactive protein, which I will show you is a marker of the level of inflammation that we carry in our body at any given time, could potentially be a better predictor of cardiovascular disease risk. And again, this link between inflammation in our bodies and the potential for having cardiovascular disease. Again, this was a classical study that showed us that link. So with that key study that was done, I just want to review with you what inflammation is. We can all recognize that in some cases, inflammation can actually be very visible. So for example, if you had a chance to be out in the sun this summer, you might recognize that some of the first signs of inflammation that we might see on the skin is a reaction to the sun, and inflammation is the body's first response to an injury. We recognize that there are certain phases of inflammation. The first phase is an acute phase. This includes redness, swelling, heat, and altered function. And we recognize that some signs of inflammation are visible while others are not. And we do know that inflammation is self-perpetuating. So in the picture at the bottom here, you see a patient's teeth, but what you might notice with the tissues that are surrounding the teeth, we call this the gingiva, or you might call it as a patient the gums, is that there's a little bit of swelling or redness that you can notice in the gums. Unfortunately, with periodontal or gum disease, the first signs to a patient that something is amiss might be slight bleeding when you floss, or it may be a dentist or a periodontist actually telling you that you've got gum disease. So despite the fact that you have this inflammation going on right under your gum line, it may not be evident to you. So you may be carrying a certain burden of inflammation in your body in the oral cavity without even recognizing that you have it. Whereas if you cut yourself or got an infection or had sunburn, you would recognize that you had an inflammatory response going on. So hold that thought right now, and I'll go into, again, the signs and the results of what we call gum disease, or more professionally, gingivitis and periodontitis. Now, I won't spend a lot of time on this graphic. I just want you to recognize that any challenge to almost any tissue will result in what we call cellular and molecular changes in our body. And basically what this shows is that as we have an insult to our body, there can be activation of what we call preformed mediators. And in addition to these mediators, we can have activation of our genes that will result in proteins that can kind of fight the challenge to our body. The very first result of this is the recruitment of what we call leukocytes, which are cells that are going to migrate into the area in response to this challenge. Again, many cells of our immune system will react in turn. These will secrete proteins, and at the top I want to point out that one of the acute phase proteins that is expressed as a result of the challenge to the body is this protein called CRP, or C-reactive protein. And again, I want you to remember C-reactive protein, as I mentioned from the Ridker study, because this will serve, as you can see, as a marker that we will use to monitor the levels of inflammation in our body. And this shows you why C-reactive protein is expressed during the inflammatory cascade. In the middle of this slide, you see these second stage cytokines called interleukins, for example. And then there are other proteins at the bottom. One is called MMP or matrix metalloproteinase, etc. But this results in inflammation, early mobilization, what we call a pro-oxidant state. And in the case of soft and hard tissue, some remodeling that will go on as our bodies resolve the inflammation, the inflammatory insult. Now, if we look at the history between people thinking about what's going on in the oral cavity and what might happen systemically, we recognize in the 1800s there was this thought about what we call Koch's postulate, linking bacteria to disease. And Koch's postulate was basically that microorganisms should be present in every case of disease. You should be able to isolate the bacteria and grow them in culture. And then if you were to take these bacteria and inoculate them in animal models, you could replicate the disease, and that you could then isolate these microorganisms. So this link between bacteria and disease was, again, scientifically proven in the early 1800s. At the same time, if you look at the dental literature, and many dentists might have been physicians at this time, you can see that W.D. Miller in 1891 talked about the human mouth as a focus of infection, and Hunter in 1900s postulated that oral sepsis was a cause of general disease. So this thought about what's going on in the oral cavity might cause disease at distant sites, certainly historically was documented. The problem with this is there weren't any randomized controlled trials that were done. And eventually when people looked at this, they really did not find a link between what was going on in the oral cavity and what was happening systemically. In fact, during this era, many physicians and dentists were prescribing extraction of all of the teeth to cure systemic illnesses. Now, if you look at the progression of periodontal disease or gum disease in humans, there's a classical study that was actually done in Sri Lankan tea workers. These were individuals that never had any kind of dental care, never saw their dentist for regular care. And what they were trying to ascertain is what is the natural progression of gingival or periodontal or gum disease. And interestingly, what they found when they looked at the outcome of lost teeth is that there's a group in red that have natural progression that can basically be very severe in nature. There's a group represented by the gray line here that will have what we call a chronic form of this disease. In other words, you may have this disease that starts typically in your 20s, but will progress at a very slow rate throughout your lifetime. And then you have a very low cohort, about 11% of the population, that will be resistant to this disease. So right now our understanding is that for the general public, about 80% of our population will have this chronic disease that's happening with gingivitis or periodontitis. 8% of the population will be in a category that's severe, and about 11% for a variety of reasons will be resistant to the disease. Now, our understanding of periodontitis, and again, periodontitis is the term that we use for inflammation of the surrounding tissues around the teeth, is that it's a bacterially induced chronic inflammatory disease that destroys connective tissue and bone that support the teeth. Again, if you look at the picture of the oral cavity that you can see in this slide, you'll notice that the gums right around the neck of the teeth appear to be swollen and slightly red, and this is a sign of inflammation. So the bacteria that we know cause this disease can get slightly under the gum line, and if they're left there, they can cause your body to have an immune response or an inflammatory response that results in this kind of appearance of the gum, this redness and swelling. Now, exactly to the side of the picture that you see of the teeth, you see dental x-rays. And on the one hand, you see an image in the middle that has a black line going right around where the neck of the teeth are on the x-ray. And right underneath the crowns of the teeth, you can see what is the bone that we see on the X-ray. And I can tell you that that X-ray in the middle here signifies that this patient has had no bone loss, as opposed to the X-ray that is exactly next to that picture, where between the points of A and B, you might notice that there's an area of black. And indeed, what has happened here is due to this chronic inflammation, this chronic disease that's happening underneath the gums, the bone around the teeth has actually dissolved. So the inflammation has caused loss of the connective tissue. And in fact, if you look at the picture right below it, you'll see that there's a picture of teeth in what appears to be this yellowish, cloudy material. That's the jawbone. And in the arrow with the black, what you see is the result of gum disease or gingivitis and periodontitis, which is the loss of the bone around the neck of the teeth. So approximately 30% of adults do have this disease, and 8 to 13% have severe generalized disease. Unfortunately, as I mentioned, for the most part, this is a painless disease. If it was painful, you would know about it and present to your dentist with that symptom. It can go throughout your life for many, many years without it being noticed by yourself. Typically, it will get diagnosed either by your dentist, your hygienist, or periodontist when they take x-rays and look at your teeth. On occasion, you may have symptoms of bleeding when you brush or floss. So again, this shows you what happens. In the middle here, you see a picture where the plaque is represented underneath that gray circle. Plaque can collect around the neck of the teeth, and if you're not brushing and flossing well, it can accumulate underneath the gum slightly. And what you see on the one side is healthy appearing gum, but on the other side with the black circle, you notice the redness around gum. And that's a sign of what we call inflammation of the gum or gingivitis. Again, in the picture below that, you see what you might see on x-ray, normal bone around teeth, but in the black circles, the beginnings of loss of bone around the neck of the teeth. And eventually, you can see that this disease can progress so much that your teeth might start to become loose. And instead of losing your teeth due to decay or cavities or caries, you can indeed lose your teeth because the support around the teeth will get dissolved due to that chronic inflammation. Now, we also understand there are things that can make this disease go faster. So for example, if you're a smoker, you're at higher risk for progression of the disease. If you have uncontrolled diabetes, your disease can progress at a faster rate. And indeed, we believe that there are some patients that might have genetic risk factors that make them predisposed to this disease as well. So in summary, what I've tried to do is convey to you that periodontitis or gingivitis is caused by bacteria. The bacteria, in turn, will cause your body to react in the form of inflammation. And remember what I said about inflammation and C-reactive protein. You might hypothesize from what I've told you so far that with inflammation, you might expect C-reactive protein to go up around the gum line. And I will show you that there's potential for this inflammation that is in the oral cavity to potentially get into your bloodstream and spread to other areas of the body. So again, hold that thought for now. Now, over time, with scientific kinds of discoveries, we have learned that our first hypothesis about how this disease progresses was one that was a very linear one, that people will get the disease at some point and it will progress throughout their lifetime in kind of a chronic way, like many chronic diseases. But what we understand now is that there are many different models. I shared with you the model where people might have no progression. Some might have a burst of progression with remission, and others might have periods of remission and regression. With the advance of molecular techniques and techniques to study microbiology and clinical trials, our understanding of how this disease is caused has progressed. And in the 1990s, right here in the Boston area, actually at the Forsyth Institute, Our microbiologists like Sig Satransky and Anne Haffajee really discovered that out of the 400 to 600 kinds of bacteria that live in the mouth, there are only, I would say, about 15 to 20 putative pathogens that cause disease of the gingiva or of the periodontium. And in fact, this graphic here shows you many of the species of bacteria that have been identified. And not only have they been identified as bacteria that cause the disease, but these exist in a microenvironment within these complexes that I show you here, sometimes called an orange complex or a red complex. And we believe that some of these complexes may be involved with the progression of the aggressive kinds of diseases or the chronic kind of a disease. Now, like I mentioned, these bacteria that we know cause the disease. If you hypothesize that bacteria cause the disease, like I said at the beginning of this talk, what you might say is that you would expect the body then to react to these bacteria, and a byproduct of the reaction of the body to the bacteria are what we call host factors. In other words, you would say you would expect to see these inflammatory mediators be expressed at a higher level right in the gum area. And indeed, when we've done studies, we found things like prostaglandin E2, interleukin-1 beta, collagenase are expressed at higher levels. So we know that the body is expressing these mediators to fight the inflammatory response. And indeed, many of these inflammatory mediators are known to be present in other types of diseases, such as arthritis, for example. So now we know that we've got bacteria that cause this disease. We know that the host reacts to this disease, and that's been proven. And the issue that we face is one of balance. In other words, even though these factors are protective of the bacterial insult, if they are what we would call overexpressed, by their very nature, they can cause damage to the body. In other words, they can cause the bone around the teeth to dissolve in very simple terms. And just like we're learning in COVID-19, we react to the virus, but this storm of mediators that is released causes damage to our organs in the form of not only our lungs, but now we're understanding organs that are distant to the viral insult. So with that introduction, I had to talk to you about, obviously, the inflammatory component to understand where C-reactive protein is expressed. And I had to speak to you about periodontal disease and what we understand about it. I'm now going to talk about how we might link what is going on in the oral cavity to systemic disease, and I'll basically focus in on cardiovascular disease. So just like we're learning with COVID-19, we take a very scientific approach to understanding the mechanism of disease. We take a very scientific approach to understanding treatments and vaccine effects. We go through this cascade of thinking. Temporal expression. Does the cause of the disease precede the effect? Is it plausible that the association that we're hypothesizing happens? Is there consistency? Is there strength? Is there a dose response? In other words, if you have a more severe form of the disease, would you see more severe expression of inflammatory mediators? If you treat a disease and take away the bacterial insult, can you reverse the cause of the disease? Again, study design, randomized controlled trials, and evidence are critical as well. So what I'm going to try to do is talk about the link between oral disease and systemic disease, and then give you this kind of thinking when it comes to the link between oral disease and systemic disease, hoping that you will see that there is a body of evidence that supports our hypothesis. Okay, so let's think about this. Does the cause precede the effect? We know that periodontal tissue destruction is caused by inflammation. We know that there are inflammatory modifiers that can affect the rate of progression of periodontal disease. Like I mentioned, if you're a smoker, you would have a higher risk of periodontitis. The end result being periodontitis. And then the question is, If you have moderate to severe forms of this disease, is it plausible that what's going on in the oral cavity could get expressed into the bloodstream and add to the overall body's inflammatory load? And in turn, is there a point where the body's total systemic inflammation might cause chronic diseases? So this is kind of the whole model that we're thinking about. Think about your body being a reservoir in the bloodstream of inflammatory mediators. Some of those inflammatory mediators may be coming from chronic diseases in your body, a spot where you have arthritis, a spot where you have periodontitis. And eventually, that total amount of inflammation as measured by C-reactive protein can have effects on other organs and other diseases. That's really the whole hypothesis here. Does the cause precede the effect? Again, think about a periodontal infection that I've talked about. And just to give you a picture of kind of the total surface area that we're talking about, it's been said that if you have moderate to severe periodontitis, that the total amount of inflammation that you might be carrying at any given time would be the equivalent surface area of inflammation to your hand. Imagine having a surface area the equivalent of your hand on any part of your body that you could visualize and not treating it. If you're a diabetic and you have that kind of wound that was on your foot, you would treat it immediately. The challenge we have is, like I said, this disease in the oral cavity is silent. It's underneath your gums. And that's why the aggressiveness of our treatments has to be there to try to diminish the amount of inflammation anyone's carrying at any given time. So anyway, periodontal infection, there are whole bacteria that are under your gum. There are bacterial products that are under the gum. And there are these mediators that I said that get expressed under the gum. These are known facts. Now, we might think of gingivitis and periodontitis as being localized to the oral cavity, a local infection. But we now know that these mediators, bacteria and products, can actually get into the bloodstream. And we have evidence that you can isolate these bacteria from the oral cavity in the lungs, around the heart vessel, and actually even in knee joints. So if we carry that further, we recognize that no matter where these products go, they could cause distant sites of inflammation. These can be expressed in blood vessels, in the liver and pancreas, and indeed even in the placenta or uterus. And that's where we think this link to cardiovascular disease, diabetes, and even preterm low birth weight babies can happen. So again, this is temporal in nature. It's an expression of a hypothesis. And this shows you the whole schematic that we think of when we think about this. Here you see basically a study that was done showing that pathogen-induced inflammation on sites distant from oral infection, showing that bacteria can be present in heart vessels, these bacteria being isolated from these areas, and they're basically bacteria that are in the oral cavity in form of the periodontal pathogens that I mentioned. So people certainly have shown biological plausibility. Here's a model of how this might work. I won't go into any details. Strength. What is the strength of the association between the cause and the effects? And here you see large studies that have been done under the column N, the numbers of patients that were looked at in many different countries. The outcome that they're looking at, either cardiovascular heart disease or stroke, controlling for other risk factors. And you see that patients with periodontitis in these studies did indeed have higher rates of risk for cardiovascular heart disease, again, mitigating for all the other risk factors like cholesterol or obesity, etc. So good evidence in these epidemiological studies that there may well be a link. What is the strength of the association between cause and effect? And again, I'm not going to go through this in a lot of detail. Here's a meta-analysis looking at risk factors, another large study, a systematic review looking at risk factors. And again, these large studies that are systematic reviews or meta-analysis do show an increased risk for patients having cardiovascular heart disease or atherosclerotic disease if they have periodontitis. Here we see the dose response. In other words, if you have more severe forms of the disease, is there an increased risk for cardiovascular disease? Again, I won't go through the detail, but good evidence if you measure C-reactive protein in the body with patients with periodontitis, the more severe the level of the periodontitis, the higher the level of C-reactive protein expressed, not just in the local area, but actually at the systemic level. So good evidence from these studies that yes, indeed, the more severe the disease in the oral cavity, the higher the level of C-reactive protein in the body. Again, looking at dose, increased exposure and increased effect, similar kinds of studies, looking at C-reactive protein in systemic levels and periodontitis. And the take-home message is severe periodontitis is associated with an increase in high C-reactive protein levels. Now, this is another level of evidence that we look at. If you remove the cause of disease, can you decrease the risk of the effect? And again, studies being done, if you have a deep cleaning or a cleaning, you do show that you can affect the level of C-reactive protein in the body. So again, by treating the disease, you lower the local inflammation, and hence you lower the total body levels of inflammation as measured by C-reactive protein. I think this was an interesting study published in the New England Journal of Medicine. Specific question was, can intervention in the form of doing a deep cleaning or a scaling and a root planing affect a systemic outcome? This study was published in 2007 by Dr. Tonetti et al. And in this study, they took 120 patients that had severe periodontitis, and half of them were treated intensively with what we call scaling and root planing. The other basically received regular care. And one of the things they measured was endothelial function, which is basically measuring systemic kinds of responses, and inflammatory biomarkers at a certain period after the treatment. The conclusions from this study was intensive periodontal treatment resulted in acute short-term systemic inflammation and endothelial dysfunction. However, 6 months after therapy, the benefits in oral health were associated with improvement in endothelial function. So if you interpret these results, you might say, right after a deep cleaning, you kind of create this storm of mediators that goes into the body because you're disrupting the oral cavity and causing the spread of these mediators. So right after treatment, you see this surge of inflammation in the body, but 6 months later, it's actually much lower than the beginning. So you've actually affected kind of systemically the measure of the amount of inflammation that you're carrying. An important landmark study. So as we come to the conclusions of my talk, we recognize that the chronic diseases of aging are connected through common inflammatory mechanisms. We recognize that inflammation levels differ among individuals, and for the most part, if we control the disease, we control the levels of inflammation. We recognize that treating periodontitis reduces systemic inflammation, and this in turn may improve diseases that are influenced by inflammation. Remember how I started my talk with the fact that many medical and dental oral health researchers recognize that inflammation in our bodies is a common cause for many chronic diseases of aging. So you might say, well, what do we tell our patients? The American Journal of Cardiology and the Journal of Periodontology put out some recommendations. They said patients with periodontitis and atherosclerotic cardiovascular disease should be informed that periodontitis may raise inflammatory biomarkers associated with increased risk for CVD events. Patients with periodontitis should assess their risk for future CVD events and coronary artery disease. In addition to that, periodontal evaluation should be considered in patients that do have atherosclerotic disease, especially those that have signs and symptoms of gingival disease, etc. And periodontal treatment to reduce risk should be focused on reducing and controlling bacterial accumulations and eliminating inflammation. So part of this is really talking to our patients about these connections and chance for risk. We all recognize what a wonderful job our dermatologists and cancer colleagues have done in talking to us about the risks, for example, of being in the sun and the links between that and cancer, or the links between lesions that appear on our skin and getting those checked out. So I would say our cardiovascular and medical colleagues need to understand what the signs and symptoms of periodontitis are and inform patients about those links. And in turn, our patients that we see in our offices should be told about those links and be placed on frequent recall and maintenance programs. I'm just going to close talking a little bit about diabetes, just for your interest. We recognize that there's a real epidemic of diabetes in this country and obesity. And many of our studies have looked at the link between diabetes and periodontal disease. There's recognition, like I said, if you have diabetes, you're actually at higher risk for periodontal disease, especially if your diabetic state is poorly controlled or not controlled. The question we asked is, by treating periodontal disease, can you control one's diabetic state? And indeed, people have done studies to show that with cleanings and deep cleanings and good maintenance, periodontal therapy can lead to better glycemic control. And in fact, the interesting thing about this point is that there are now some dental insurance companies that actually are allowing patients with diabetes and other risk factors to get 4 cleanings a year, simply because when they look at the patient's medical costs, they find that those patients have lower medical costs. Why wouldn't you want to be an insurer and lower your medical costs by offering your patients 4 cleanings that are covered by insurance rather than 2? You know, when I was at my previous institute and first came to Tufts, I had many areas of interest, of research. These are some of the areas that I was focused on. Many of the people that I collaborated with at the Joslin Diabetes Center, Forsyth, the Beth Israel, Brigham and Women's, and some of my partners in the corporate world as well. Here are some of my colleagues that I've worked on. Special thanks to Ken Kornman from Interleukin Genetics, and certainly parts of this presentation I attribute to his work and his presentations that he's done in the past. So to answer my question, between oral and systemic links, is it fact or fiction? Certainly we see the evidence that I presented to you. We do believe that there's a link, but it's certainly a work in progress. It's not a clear cut, you have periodontal disease, therefore you have cardiovascular disease. Like many diseases that have multifactorial etiologies and the body's reaction to them, every individual is different. But we do need to understand risk and convey that to our patients. With that, I'm happy to, I think I've finished on time, happy to entertain any questions that might have come up. Thank you very much for your attention.
Okay, we got some fantastic questions, Dean Karimbux. The first question is very relevant, and I think it's something probably many in the audience are wondering. It is, what degree of certainty do you have regarding the safety of routine dental cleanings during the COVID-19 crisis? Specifically, can the aerosolized virus affect the patient who lies with open mouth in the dentist chair? Should the risk of inflammation and periodontal disease be secondary to the greater COVID-19 risk?
Yeah, that's an excellent question. You know, I actually was quoted in a USA Today publication a couple of months ago about the safety of treatment in dental offices. The big worry for dentists was one of their own safety when we think about healthcare providers on the front line and the number of our medical colleagues that were getting exposed to the virus. And this was at a time when, clearly they were on the front line in terms of treating COVID positive patients. And the fact that they didn't have the right PPE supplies or protocols. What I can tell you is that not only from friends of mine that have visited the dental office, the standards that dentists have set for themselves, not only during the COVID-19 pandemic, but pre-COVID, have been protocols that I think started at the HIV outbreak and have really led to a lot of safety for dentists and their patients. For example, the fact that dentists wear gloves and masks and eye protection and offer eye protection to their patients is a standard of care for us. And, I can remember, pre-COVID going to see my eye specialist or my physician and having them actually very close to me without those kinds of protections, looking in my eyes, my throat, my ears, etc. So from a protective perspective, I can say that the amount of PPE, the protocols that dentists are currently required to not only protect themselves and protect their patients is extremely high. And the fact that dentists are wearing respirators and face shields and, covers and so forth, not only protects them, but protects their patients from spread of the virus. On the aerosol piece, again, I think dentists have taken precautions with aerosol capture units that capture aerosols. I just spoke to the president of the ADA, one of our alums, Dr. Kathy O'Loughlin. And to date, there's been no documented global worldwide transmission of disease from patient to dentist or from dentist to patient. Obviously, there may be exposures that we haven't heard about. Some of the exposures that we heard about in Wuhan, for example, at the dental school there, that happened amongst their dentists and staff happened in the community. So we're a lot more worried, for example, about people in the community coming in to our settings. To that end, for example, at Tufts University School of Dental Medicine, all of our providers that are patient-facing are getting tested on a weekly basis. And again, we believe that with our protocols of questioning patients when they come in, everybody in every workplace and dental office is self-attest to their symptoms, stay home. So in a nutshell, I believe that it's very safe to go and see your dentist and not be afraid of any kind of spread. The infection control protocols between patients when aerosols are used are very, very strong and guided by both the CDC and OSHA.
Thank you, Dean Karimbux. I have another great question. How did diabetes, diet, and smoking affect the mechanisms linking inflammation to disease?
I think that's a great question. We're starting to learn, obviously, about a lot of interrelationships between, diet, obesity, diabetes, inflammation, etc. Like I said, I think most people are thinking that the common link here is really the inflammatory response and the amount of inflammation we as individuals are carrying systemically at any given time. So I think all of these things are related in that way. So for example, I talked about periodontitis and inflammation that is local, but clearly can affect systemic levels of inflammation. We recognize that diet certainly can play a certain role in the amount of inflammation that we've had, not only perhaps in what we're eating, but also in what obesity means and certain types of obesity in certain ethnic groups as well. Genetics will certainly play a part. Diabetes, I think there are two aspects to it. One is if you have diabetes and it's untreated, it puts you at risk, I think, for several different diseases. Like I mentioned, you're at risk for periodontitis. We recognize that you're at risk for retinopathy and other types of foot ulcers, etc. And the converse is true as well. If we can then control inflammation through a variety of different sources, whether it be diet, deep cleanings, etc., we can improve our glycemic control and improve our diabetic state. So all of these things are interrelated. Like I said, what's fascinating now is the thought that that C-reactive protein and inflammation in our body has a major role to play in all of these diseases. And then our genetics and environment as well are critical because, genetically, we might be one of those patients that's resistant to periodontitis. Remember, I told you 8% of the population are resistant. But equally as important are those people that might have a genetic predisposition to disease. So if you take, for example, one of the inflammatory mediators that I discussed, interleukin-1 beta, we kind of know now that some people might express levels of interleukin-1 beta that are protective but don't harm the body. But other people might overexpress interleukin-1 beta, and that might cause harm in the form of the tissue that dissolves around the gums or more inflammation in the body.
Right, thank you. I have another group of questions that are kind of the same. What if the dentist says there's serious inflammation in the mouth, but then the physician doesn't recognize the connection?
Yeah, I think that's something for oral healthcare providers really to start stepping up and doing is really educating our medical colleagues to the links between oral disease and general disease, and not only that, including in their general exam, a look in the oral cavity. And you can just look in the oral cavity and recognize signs and symptoms of this disease in terms of redness and make the referral. Or you can ask a simple set of questions in a questionnaire that have been validated, where they might say, you've answered some questions, therefore you should be referred. I do think that technology will help us in our relationships with our medical colleagues. So we're talking about electronic health records that are basically common to both dentists and physicians. So that transmission and linking of health data will be useful. I think on the education front, we're talking about interprofessional education. So making sure that all healthcare professional students are educated two ways about not only oral issues, but medical issues. I think some of our healthcare workforce that have more time with us should be educated, whether it's physicians' assistants, nurse practitioners, hygienists, who may not be as busy in terms of seeing volume of patients, but could, basically speak to patients about these risks and so forth. So I do think it's important. It's an important role, and I do think technology and gleaning of information, artificial intelligence, taking information and actually instructing patients about their risks through apps and stuff. All of this, I think, will start to shift as we see the technology lending itself to collecting data and presenting it to patients in dashboards as well.
Okay, this question is along the similar line. Given these findings, why is dental care not covered by health insurance or Medicare?
Yeah, that's a great question. I think it points to probably a couple of different things. One is, certainly I think each profession likes to hold its own turf. And some of it has to do, I think, with turf issues. Dentistry, basically, I think as a profession, hasn't been in managed care programs or healthcare programs. Certainly in certain times, I think loses out. So for example, during the COVID-19 pandemic, I certainly saw here at the dental school running a large clinic that we weren't privy to some of the programs that reimbursed for Medicare as relief funds. So those separations, I think, have existed for a long time. But I do think now that people are seeing links to general well-being, that there are medical groups that are incorporating now oral health. Kaiser Permanente in the West stands out as a model program where dental care is provided within their clinical settings, reimbursements are provided within medical settings. So I think that landscape is starting to shift and change so that things are covered. But you talk about access to medical care. I think access to oral health care is a huge issue in this country, simply because of the way that things are set up. So as the healthcare shifts and changes here as well, I think access to oral health care and coverage certainly will be a part of that discussion. And like I said, I think medical insurers are discovering that patients with good oral hygiene actually do have good medical outcomes as well.
Okay, thank you. Another question is, are there any specific behavioral modifications such as diet patients can make in order to reduce their periodontal disease and overall systemic inflammation?
Yeah, you know, we know that there are many risk factors that have been identified for getting periodontitis. You know, the ones that I've expressed are probably the strongest links: smoking and certainly diabetes. But we know that there are other risk factors. Age happens to be one. Being male more than female happens to be another one. Socioeconomic status and diet has been implicated, but I would say the evidence, because it's so difficult to kind of have a randomized controlled trial around those kinds of things, certainly I think will play a role or could play a role, but again, no clear link there right now. It really is more, I would say, the evidence that we've got for diabetes and smoking are probably the two strongest risk factors that we know for periodontitis. Otherwise, I would say, you know, good oral hygiene habits in terms of prevention, to include brushing and flossing and visiting your dentist, so that if there are early signs and symptoms that they pick up routinely by doing exams of the periodontium and taking x-rays, that those can be picked up early for you, so that the right kinds of treatments can be prescribed to prevent the progression of the disease. It's well known that patients on good maintenance programs, 3 to 6 month recalls, very well documented in the literature, that you can slow the progression of this disease down.
That's great that we can all take care of our teeth and hopefully prevent this from happening. Yeah. Another question is it possible that not just bacteria, but chronic stress and anxiety can cause the inflammation in the gums that lead to the bloodstream?
Yeah, that's an excellent question. You know, there are links between stress and grinding your teeth and the forces you transmit through your teeth with periodontitis. And the take-home message to that is, if you have inflammation or periodontitis and you are grinding and clenching, that your risk for progression is higher than basically periodontitis alone. Clenching or grinding alone without the inflammation does not lead to progression of disease. It can lead to other issues of the masticatory system, such as wearing of the teeth, sensitivity due to the wearing, where you grind down into the dentin. It can lead to issues around the musculature and the joint. So people that grind and clench their teeth might have symptoms within the TMJ, which is the temporomandibular joint, and pain in the muscles of mastication as well. So yes, there is some relationship. Clearly, grinding and clenching can affect the teeth themselves, or, as I said, the joint and muscles. And if you do have chronic periodontitis with grinding, it can lead to progression as well.
Thank you. This is the last question. Is there a blood test for CRP in your body? And if yes, is there a proven range of good, fair, and poor? And what are treatments for CRP issues?
Yeah, that's a great question. I've really not kept up with that literature. Like I said, I think there are some leaders in the cardiovascular area, like Ritka's group at the Brigham, that kind of discovered this link between C-reactive protein, the study that I showed you. I don't think that routinely they are using C-reactive protein as an outcome. I know because, you know, I have high cholesterol and I'm on a statin myself, and I still think that the gold standard they're using for medical reasons, medical outcomes and data, is things like cholesterol levels, although those get modified as well. But I don't recall looking at my blood tests, which obviously a lot of us can access through these patient portals now, and seeing C-reactive protein as anything that's being used as an outcome measure yet. But this whole area is starting to come together in ways that we can't imagine. You know, the fact that when I saw my physician, I was able to take a genetic test, because people of Southeast Asian ethnicity are at higher risk for cardiovascular disease, and submit that through a swab and get results back. It's just amazing to see the diagnostic advances that we're seeing. And if you think about the COVID-19 outbreak and how quickly companies responded to testing. Obviously, the testing could be much better in terms of the way it's been rolled out and distributed. The technologies that we've got are just amazing in terms of being able to pick things up. That field is just going to get more and more advanced as we move along. I think the real issue is one of the outcomes. What does all of this information really mean? And it's not until you do large clinical trials that you can really say, yes, this is important enough to change a therapeutic or a behavior to a certain extent, because these diseases really are multifactorial diseases.
Thank you. Thank you, Dr. Karimbux, for an outstanding presentation. What a fascinating look at the link between oral and systemic health. It was so interesting to learn about the link between oral health, inflammation, and many systemic illnesses. This presentation has been recorded and will be available at a later date on our Tufts Alumni YouTube channel. You will receive an email shortly with a link to a brief survey. Please take a few minutes to complete the survey, as we do value your feedback. Thank you for joining us today. Please stay safe and healthy, and have a great rest of the day.
Thank you.